Okay, so what I want to do today is talk about a number of things. I'm a clinical neuropsychologist, and what that means is I'm a psychologist who's trained as a psychologist, like any other psychologist, but also did additional training in the area of brain-behavior relationships. Psychologists have been measuring things for 100 plus years. We measure human responses to things, we measure behaviors, we measure abilities, and so it only made sense that over time we would start measuring things that started correlating with brain science, which we'd always been doing, but then somebody figured out that's what we were doing. So as time went on, neuropsychology developed as a subset of the field of psychology that really focuses what we can do, which is measurement, evaluation, treatment, from a behavioral or cognitive standpoint of people who have different types of brain disorders, anything from developmental disorders in kids to head injuries to illnesses to Parkinson's, Alzheimer's, the whole range of things. We're helpful in terms of providing diagnostic information. We're helpful in educating patients because we get to take a lot more time with our people than physicians do just by virtue of the way their world is structured. It's not, I think, it's them. So what we do is help with diagnostics. We help measure, in the case of people with brain stuff, we measure cognitive or thinking abilities. And that's really the main thing that we do from an evaluation standpoint. We also help people manage those things with a number of different methods. So, so how is neuropsychology relevant to Parkinson's? Well, with Parkinson's, it's a brain disease. I mean, it affects lower parts of the brain. It affects circuitry deeper in the brain that doesn't have so much impact on your ability to think as it does on your ability to process information quickly, efficiently, to alert to certain information. It's kind of, but it doesn't cause, in the great majority of people, the kind of drop-off that you get in Alzheimer's, which is the cortex of the brain, which is this crinkly stuff on the outside. These are the cells that do the thinking. There's more of that same matter on the inside of the brain, but there's also a lot of connections that get impaired along the way with Parkinson's as well. Parkinson's hits a more specific range of things than just lots of thinking. It hits motor, attention, that then has an impact on processing speed, and some elements of problem solving. And as a result of that, you have people who may be moving slow, they may be talking quietly, but you look under the hood, there's plenty of humming going on in there. The brain is going. People know what's going on, they know who they are, where they are, what's going on. They can tell you about anything pretty much going on for the most part. People with Alzheimer's don't think they have a problem. They're much more impaired, and that's from early on. It's a totally different thing. So it's important to be able to look at cognitive functioning and be able to differentiate between people with something like Parkinson's and the effect that's having on thinking versus something like Alzheimer's. And one of the reasons it's important is because people get mixed up between dementia, meaning Alzheimer's, meaning all kinds of things, versus perfect. So either if you have a little bit of something going on cognitive or even a moderate amount of things in terms of cognitive functioning that aren't working as well, it's easier for the person having that, or even worse, family to go, oh, well, they're all gone now. It doesn't work that way. And I want to make sure that the testing is a good way to be able to sort that out. I want to talk about dementia and the various subtypes of dementia so we can sort out what is dementia. When people say, well, they said I had dementia, it means I have Alzheimer's. No, that's not what that means necessarily. I want to talk about the specific cognitive things that we tend to see very regularly in Parkinson's, and also some dementia subtypes that you see, because there are some subtypes of Parkinson's that have dementia. I want to talk about neuropsychological testing, what it is and what it isn't. People are very scared about going through testing. But I can't tell you how many people show up in my office, and I say, well, how you doing today? Okay. A little scared. Did you sleep last night? No. How much? Well, maybe an hour. What were you doing? And I'm imagining Tex Ritter playing in my head, thinking, walking the floor over you all night long and stuck in their head. They can't, because they're worried. They say, well, I didn't know what you're going to do to me today. So we told you on the phone, and we told you in the letter, we have a website. I was still scared. So that's the kind of thing that we get often. And so hopefully we can, I'm going to walk you through what I tell patients when they get there, and hopefully tell you what it isn't. I was going to have some great pictures up there, but I ran out of time with my slide crisis. Bride of Frankenstein type things and people with wires coming out of their head. We don't do that. We go to jail for that. What to expect? What are you going to be doing during the day? What do you expect from the neuropsychologist? What should you expect in terms of service and the nature of things you get from them? This is a service for you. Anytime a psychologist takes you on, I don't care if they're just consulting for the neurologist or the whoever, they are your patient. They have a contract with you, not the institution, with you. They need to go over those results with you. And I may be a stickler about that, but neurologists they're not able to give you the full story that a PhD with 2 or 3 years of training in neuropsychology can, 2 or 4 years. So, that's another reason I want to beef on that a little bit. I'd like to talk about how we put the data together, test data together. You just pass or fail a test? Or did I fail? Does that mean, they're going to haul me off, to Happy Acres somewhere or something? And, I want to show you how that works best I can, talk you through it. I want to try to impress on you what we do with the information. The main thing is, obviously you want to answer physician questions. They'll go, well, does the patient have dementia or not? That's easy, Pretty much, no. It's the stuff that you see with Parkinson's, not so much dementia. Are they okay for DBS? Yes. Can they still drive? I think so. Those sorts of things. But when you come in, there's a whole lot of data. You spend the better part of a day talking, taking a bunch of tests, and I spend the better part of a day grinding out a report that has a lot of detail, a whole lot of thought put in it. And if it's just a yes, no question, why are we doing this? So I want, when people come in for testing, it's super important that they come back for the feedback session, because we want to go over those results and make this a useful, practical process that you walk away with something you can use. And if you don't do that, what's the point? So we'll get back to that. Now, dementia, what everyone fears the most with any type of brain disorder, whether it's theirs or somebody else's, that they're taking care of. When you hear the word dementia, and dementia is thrown around in the loosest way possible. It's like, it's a shame, because it shouldn't. It's a very powerful term that has giant, worry attached to it. Well, what it really means is, what dementia technically means is there's some loss of mental function. D meaning, downhill. Mentia, which means thinking. Well, from the time you hit 40, every day after that you have dementia, because your cognitive acuity is typically going down a little bit at a time. You don't run as fast, you don't think as fast, can't hold as many figures in your head, and can't multitask as well. So if that happens, I guess you're losing ground. Does that mean you have dementia? Dementia, And that's important, because when we look at the outcome research for Parkinson's, there's a whole lot of definitions of what they're calling dementia. And those range of definitions result in people saying, well, 11% of people with Parkinson's develop dementia versus 71% of people with Parkinson's develop dementia. Oh, well, why is that? Depends on what you're calling dementia. When I talk about dementia, and this is kind of the standard description of it, it means a substantial decline in short-term memory and impairment in at least two other key areas of functioning, like attention, abstract reasoning, spatial skills, language, that has an impact on your ability to function in day-to-day life. So that's what dementia is. Now, you can have key distinction. All dementia involves cognitive impairment. You all know what cognitive means, right? I didn't know what it meant until I was in my second year of college. I'm sorry to admit. But all dementia involves cognitive impairment by definition. If you have dementia, you have that thing we talked about here, well, by definition, you're going to have loss of cognitive function. But the opposite doesn't work that way. You can have cognitive dysfunction and not have dementia. Let's say you had a stroke 3 years ago. You have a stroke. It had an impact on you. You had a loss of some particular functions. Okay, you got a loss of cognitive function. But you're not going downhill. You still know what's going on. You have a hole in your fabric, but it's one you've learned to work around. So is that dementia? No. So just having cognitive impairment does not mean you're on this big downhill rush to oblivion. Okay? And so I think that when people use, you will see the term dementia sometimes used because somebody has a few test results or several test results or maybe many test results that are lower than average but they're functioning relatively well. So I want to make sure that we're clear about that. Really, it's the matter of degree and the effect the impairment's having on you is what really determines if this is dementia in my book. When you do testing with dementia, a person is generally unable to perform a lot of the tests. I mean, they can do them, but they're really hitting low across the board. There's another category that's come up, and you probably will hear about this, called mild cognitive impairment. I don't call it a diagnosis because it's not, it's a category. Because if you say, what is the etiology of Alzheimer's? Well, there's certain types of cell pathology going on that progresses in a certain way and causes symptoms. Well, mild cognitive impairment, it's a description. And you say, well, what causes it? Well, I don't know, but 50% progress to Alzheimer's, 50% either stay the same or get better. Well, what kind of disease is that? It's sort of a placeholder, I think. It's a description, okay. It means you're doing fair in day-to-day life. You got problems on testing. You're probably outperforming the testing in day-to-day life, doing better than testing would predict, but something's going on. That's probably I think, the general consensus of that. I just want to throw that in there because you'll hear that term and that they say, well, that means you're almost demented. That doesn't exactly mean that. So let's talk about the types of dementia that you get. I'm going to just go through the varieties. Dementia being a big category. Well, doctor, do I have dementia? You may. It's, oh, I've got Alzheimer's then. No. Alzheimer's, is dementia Alzheimer's? No, Alzheimer's is a type of dementia. So I keep having to go back and say, dementia is the category, and these are little subsets under it. And they're subsets because they're different pathologies and they do different things. And the reason that's important for you guys to understand is to sort out what's the Parkinson effect, typically, on average, and how is that different from not only the level of impairment, but the types of things and the progression of impairment you get with things like Alzheimer's. So you have Alzheimer's, and you have frontotemporal degeneration. You have dementia with Lewy bodies, progressive supranuclear palsy. These are all degenerative disorders. The last two are things that you will see either in conjunction with or usually in conjunction with or secondary to or another complicated version of Parkinson's or a Parkinson plus syndrome. And movement disorders, when you see changes in cognitive functioning, things like Parkinson's disease, obviously, progressive supranuclear palsy, dementia with Lewy bodies, again, that one kind of rides back and forth between categories. So sorry, it ended up in both. But dystonia, essential tremor. People with dystonia will have, either cramped up movements or they'll have big movements that they can't control, or essential tremor. Everybody knows what that is? You may have been diagnosed with that first before you got the Parkinson diagnosis. So when you go to do something, you have a tremor, and when you go to do it, it gets bigger as you get closer to the target, typically. Those latter two do have some subtle cognitive impairment that comes along with it. It is coming out of your brain. It is in the motor system. Something's going on. So you see some evidence of that in day-to-day functioning, but also in testing. So with Alzheimer's, let's see. Oh, I got this here. The things you typically see, and I doubt most people with Parkinson's or living with someone with Parkinson's sees these things. You have frequent forgetting of conversations and recent events. I mean, it's like, it hits you pretty fast. People notice it. A lot of repeat questions, gets lost driving. They may have empathy, pleasant, nice person, but they are not aware that they're having a problem. The memory generally starts affecting autobiographical memory. Like, are you my daughter? I don't know who you are. I've known, the wife says, you know him all your life. I don't know who he is. There were things, there's dropouts that are unexpected. It affects a broader range of cognitive functions over time. It hits the hippocampus hard, which is where memories get formed. New memories come in and turn into memories. And it hits the backside of the brain as well, which is your word library and your spatial library for faces, directions, where are things, what does that look like. And so, this also hits on the cortex of the brain, outside of the brain, the outer layer of the brain. And that's a different thing than where Parkinson's hits. This is the second most common form of dementia. Now, you see this, and it oftentimes is diagnosed as Parkinson's because people will show up and they have Parkinson's symptoms. And so the doctor starts treating them for Parkinson's, and after a while they're going, the family's saying, Andy's doing some, they're doing some weird things, or they seem to be more forgetful, or now they're starting to see people hanging around the house at night that aren't there. That's when it goes back, and at that point, we will see somebody and they'll say, is this somebody with Lewy body dementia? And, there are key things that turn up. One, you do have more cognitive impairment than you do with Parkinson's, almost invariably. And you got this hallucinatory symptom. And I don't mean sensory hallucinations if you're on too much medicine and things are kind of, real things are sort of moving around. People with Parkinson's will report that, or they'll have kind of visual, just random little sensory things go on. This is, you get up in the middle of the night, walk in the kitchen, there's people standing around. They're not saying anything, they're not doing anything, they're not threatening, they're just hanging out. So you look at them, go get your milk, go back to bed, all right, whatever. And it starts off, people will report this just routinely. Sometimes people get scared of these things, sometimes they do get involved in sort of plots, but they're never really directly interacting. One lady I saw had these kids playing with her ice machine. It really made her mad. They were making a mess on the floor, and so she said, well, I'm going to make up some pigs in a blanket. So 2 in the morning, she's making pigs in a blanket, puts them out there, thinks that'll maybe draw them off, and she says they didn't eat them for 2 days. I go, your little ingrates. Ingrates, they would, what people sometimes see people living on the house, the roof of the house across the street, or people on top of your house looking through. Best story I've heard, 2 best stories lately, these were really creative. Usually these are bland characters that people see. One lady saw gypsies at her kitchen table playing cards, which I thought was pretty interesting. And the lady who was telling me about this, she was talking about a friend of hers who had it, and then she was telling me about her dad who saw dwarves running around the house, which I thought I'd never heard that before. I don't know if that's better, have them be more entertaining, or if it's weirder because they're, But these are sort of benign, I call them benign hallucinations. But what starts happening is you'll start seeing Parkinson's symptoms come along. People don't respond that crisply to the medication like people who have Parkinson's do, and the hallucinations continue and the dementia gets worse. So you'll see people who come and go throughout the day in terms of their mental acuity. Their behavior gets either more disinhibited, meaning, no filter, or they get more and more apathetic, more than you typically would see with Parkinson's. So it becomes really a neurobehavioral symptom. There's a new drug called Nuplazid, Nuplazid. Kept wanting to call it Nucalma. I don't know, I got the wrong one in there. But this is a new one instead of Seroquel, which was used, which is a perfectly good drug. But Nuplazid is a drug that seems to hit the hallucinatory stuff that goes on with Lewy body patients, and seems to hit it pretty effectively. So it's a good medication that's come out just recently. Now with Parkinson's, you'll see it's a different pattern than what you get with Alzheimer's, where things are really kind of going down. With Lewy body, where there's a lot of functions that are still working, but there's still a bigger pattern of things dropping off. With Parkinson's, you see mild to moderate. When I see somebody in my office who's about to undergo DBS, for example, or somebody who's had Parkinson's for 5, 10 years, it's not unusual to see, mild to moderate problems in things like attention, on testing, on attention, processing speed, spatial skills. Now, it's not like they can't put things together, but they're not as good at that as they are at other things they're really good at. Those are the things you frequently see. Oftentimes, you'll see some problems on tests that measure reasoning and problem-solving abilities. You'll see people have a dip in that doesn't really reflect itself in real life functioning, but you'll see a dip in that on testing. I still can't figure that one out, but you see that fairly commonly. With Parkinson's cognitively, because of the hypophonia, unless you're coming here, you may look more impaired than you are because you talk so much quieter and you're kind of like, You look like you're on the fade. Also, a lot of patients who are being poorly medicated, they can look awful with Parkinson's, when really it's not that they're not on the right meds or they're not on enough meds. I see more people under-medicated than over-medicated a lot. And when people get on the right meds, it's like, hey, still got it. It's been interesting to see people on the post-cleanup when they get their meds worked up right. You may see some compulsive behaviors, with the Mirapex, Requip, Parcopa. Hopefully, you'll dodge some of those bullets. But that also comes up. These are things that are behaviors, but they're this is not what you see in Alzheimer's. Alzheimer's folks aren't going to go out and gamble. They're not going to go out and systematically hit the casinos or go, spend money. They're going to be much less motivated to do anything, even if you don't. Medication won't, I think, help them do it. The Parkinson's, when they're getting a bad medication reaction, there's still enough cognitive function to go get on Amazon and start ordering away. So the basic skills are certainly there. So you can have some odd behaviors or unusual behaviors that come up, partly because you got it together enough to do things and do organized behaviors. Now, the majority, I can always get an argument from any number of people out of this, but the majority of people with Parkinson's do not develop a generalized dementia like Alzheimer's. About 20%, I think, end-stage people that live without any other intervening illness may develop, or I think develop some, what they would consider dementia. Some people, and they die from oftentimes illnesses of diseases of chronic illness. Most people with Parkinson's do develop some mild to moderate cognitive impairment. Fortunately, memory is not the head of the list. It's not the biggest problem. And memory is what keeps you anchored down. Some of the studies have said between 11 and 75% of people with Parkinson's develop dementia. Like I said earlier, all depends on what you're calling dementia. If you're calling dementia, if you have poor performance on 2 neuropsychological tests and you have dementia, well, that's not dementia, but if you're going to call it that, of course 75% of people have it. And what they don't measure is how many other people have, that don't have Parkinson's, or those criteria, have dementia too. So you got to read the studies before you got to look at the guts of the studies before you can understand how they're putting that. Because when I started looking at this stuff, I was going, wow, what a big variation. It's like, oh, they're calling impairment on one memory test dementia. Well, you had to give a lot more than that to figure out if it's dementia or not. So, I think that the odds are that you're going to live, if you have Parkinson's, and you have it a long time, the odds are you're going to live a whole lot longer without dementia than if you do develop it. It's not the rapid onset for majority of people. That's my experience. And I think the research says it. Don't know about the age of onset of Parkinson's. If you get it at a certain age, does it put you at higher risk for dementia? I don't know. We see a lot fewer patients with Parkinson's who don't have dementia, who have more the kind of milder, more limited range of deficits that I've talked about. Alzheimer's, the question has come up, if you have Parkinson's, does that place you at greater risk for Alzheimer's? And the answer is no. Alzheimer's risk stays the same whether you have Parkinson's or not. The Lewy body risk, I think that's when things get more mixed up and it's not as clear. Because people with Lewy body get Parkinsonian symptoms and sometimes they're hard to peel apart. Is this Lewy body or is it Parkinson's with the Lewy body dementia kicking in? So bigger minds than that can probably sort that out. But my understanding is repeatedly is that if you have Parkinson's, you are not at higher genetic risk for Alzheimer's. If you get both, you just have bad luck, not that one predisposes you to the other. Although you can get dementia with Parkinson's, dementia is not Alzheimer's, unless it is Alzheimer's, and that's not, it's a different risk. Now, typically what we'll see with people, I kind of covered this already, when we test people, early to middle stage Parkinson's, they say they've had it for 5 years, 10 years, they're thinking about DBS, or they're just starting to have cognitive symptoms. That's when people come to see me. Doctor will say, They've had it for a while, and now they're starting to kind of feel it cognitively. So that's when I get a referral, typically 5, 10 years out, is sometimes 15, 20. You almost invariably are going to see problems with paying attention, processing speed, problem solving, memory deficits. The people complain of memory problems. But I don't know if you remember being a kid in church, you're sitting there going, okay, I'm going to stay up, pay attention today. And about 2 minutes into the sermon, you're gone. You're looking for something to do. And, you could tell your mother everything that happened yesterday, but if you ask you what happened in the service, no clue. You couldn't pay attention. You can't pay attention, it's not going to get into memory. So attention has to be working pretty well for things to get into memory. I'll never forget, I was working real hard on a report. Employee comes in and says, I need to take a week off in 3 weeks. I said, okay, that's great. She comes back a couple of weeks later. I said, hey, it says here you're taking vacation next week. She goes, yeah, I told you I was going. You were sitting right here, so what was I doing? You're working on that report. I said, did I look up at you? No. I said, well, I probably answered yes, and it's fine with me, but I have no reason for that because I was busy. I couldn't pay attention to both. And that's what I'm talking about. So people will complain of a lot of memory problems. It's interesting when you look at Parkinson folks, on average, and very, very predictably, you'll see drop-offs in attention. But when you say, okay, all hands on deck, now hear this, here's some information, I'm going to tell it to you, stick it in your memory, and I'm going to come back a little later and ask you, they do pretty well, like pretty normal. Spatial memory is a little worse. So attention, again, keeps coming back as a key deficit. So now, what is neuropsychological testing? I'd say if you've been through a speech therapy evaluation, but what you're going through here is not your typical speech therapy evaluation because you're focusing mainly on voice and phonation. I don't know how much, you're not doing a whole lot of specific cognitive. Speech therapists taught me most of what I know about cognitive rehabilitation therapy years ago in rehab hospital. But people have all kinds of crazy ideas about testing, and I'll get to that in a little bit. But what we're doing is taking standardized measures. We do have procedures. Like I'm going to read you a list of words. I want you to remember them, come back later. It's a fixed set of words. It's a fixed protocol, fixed time delay. Same deal. And we can take how you do on this particular thing and compare you to groups of people that have, who are unaffected or who have this disease or that disease, whatever, and can compare how your performance matches up to other people of your age, sometimes age, education, even gender. So if we're saying, where is this person compared to where we think they would statistically be on average? We can see if you're kind of in the middle or you're on the high end, low end. Now each test we do is going to generate maybe one score or maybe 100 scores depending on, especially the ones we can score on the computer, they can just spew out loads of data. But we get a whole bunch of information from a test that compares you to other people your own age and education. So if we start collecting data, looking at it like a blood test in a sense. They take a panel, you get 40 things looked at, generates a bunch of numbers. You go, what do those mean? Then you got the high-low, which is kind of the statistical readout on it. Is it where it ought to be, or is it up or down? That's what we're doing. So we don't give you one test and say, okay, you fail. Oh, bring them in, guys. Go get the paddy wagon, take them off. It's not that way at all. We're measuring. We're trying to get the terrain of what's going on to give you some much more refined and a lot more detailed information about here's how you're functioning. Here's why we think you're having some of the dropouts you have in day-to-day life. We think this explains some of the phenomena you're talking about, and these are things you can do that may help, or this is what your family needs to do to help, or not help. Stay out of your way because you're doing okay. So we'll look at a lot of these things. Like I said, just reference to age, sometimes age and education, sometimes age, education, gender. But we get a big profile of strengths and weaknesses. And so, how is this different from a neurological exam? Well, the neurologist will say, squeeze my fingers. Well, we say, squeeze the dynamometer. So we get numbers unless he's got a dial on his fingers. And it's a perfectly fine test, but we get to measure this stuff. We measure stuff very systematically. Instead of a brief screen like they do the mini mental state exam, spell world backwards and draw these figures and that stuff, which is fine. We get good information from that too. But we get a whole lot more information and a lot more detail that allows us to talk about a lot more of your life, not just, gee, your score has gone down 2 points in the last year. And that's the whole point, is covering the whole landscape and saying, so as we look at the big picture, what's going on with you, these are the things that are working, not working. This is what tells us about the things you're curious about, or your doctor or your family are curious about. So that's where that profile of strengths and weaknesses comes through. Things we look at, I think that's probably already clear. We'll look at IQ testing, by the way, intellectual functioning. Let's forget about IQ scores. First things people ask, what's my IQ? I'm like, well, when you have a brain problem and I use an IQ test on you, it's not an IQ score anymore. It's 11 different tests, right now 10 different tests now, that tell us a little bit about a lot of different areas of functioning. And that's all. And we can play around with some of these things. We can limit test with some things and get to know some important things, but it's not an IQ test anymore. So you may have somebody who's really smart, 120 verbal IQ, but when it comes to having to put things together or process things quickly or hold a lot of information in mind, what we call working memory, they may score real low. So their IQ may come out 89. Well, they got 120 IQ here. They're 89 full-scale IQ. What does that tell you? That's like going to the French room, having the 5-course dinner. They come out, they pour it in the blender, pour it in a bowl, and say, bon appetit. You know, it's like, well, they said, well, it's all there. You got all 5 courses. You don't do that. We want to, you know, those pictures where they see a car that's kind of exploded out, and you see all the pieces in midair. That's what we want. We want to see all of it kind of hanging there so we can see how it all fits. We'll look, like I said, look at memory. Academics are reading, spelling, math. Spatial skills, sensory motor functioning, emotional functioning. Typically with emotional functioning, we're generally, unless somebody's in a lot of distress, we're looking just at mood. And there's some cheap, or some quick mood questionnaires that are useful. They're short to give. They're not real, onerous to take. And so that tells us usually what we need to know. When somebody gives you a test that looks at emotional functioning, even if it's just a symptom test, they better take into account that you're also reporting Parkinson's symptoms. So on the Beck Depression Inventory, for example, there's 21 categories of questions of which the scores run from 0 to 3. So sadness, I'm not sad. I feel a little sad. I feel really sad. I feel so sad I can hardly stand it. Okay, so you'll have like that kind of a breakdown. Well, Parkinson folks can score high on this because you go through, it'll say energy. Yeah, I've got low energy. Concentration, not so good. Sleep, not great. I feel disappointed in myself. Yes. Don't have the get up and go I used to have. Well, yeah, if you look at the things that people with Parkinson's live with, and they're answering honestly, of course they're going to go up on that. So you need to be honest about it, but you also need to hold the examiner's feet to the fire if they're saying, oh, you're terribly depressed. You go, well, let's take a look at what's really depressed. I mean, that's an important thing for anybody who's a neuropsychologist who's looking at someone's emotional functioning. You better look and see, are you measuring their actual symptoms of physical symptoms, neurobehavioral symptoms, or is this just the effects of the disease, just the drag on there? And if people try to say, oh, you're horribly depressed, and you're saying, well, you better take a look at that. Or if you really are, then you say, well, you're right. The use is for neuropsychological testing. The first thing is always diagnostics. I mean, somebody's coming in, doctor or you say, I want to know what's going on with me. Do I have Alzheimer's or what? I have Parkinson's. Am I losing my mind? Am I crazy? My kids think I shouldn't drive anymore. Or the kids bring them in and say they're crazy, they're losing their mind. And you're going, I'm not that bad. But somebody has questions, and they want to answer that. Medical diagnostics generally are going to be, let's say for DBS, does this person have a level of cognitive impairment that makes them a bad candidate for DBS? Because if you do deep brain stimulation on someone who's teetering on the low end of cognitive functioning, it's not a great idea. And it's typically has less than optimal, if not a bad outcome. So we want to make sure this person's far enough they're doing well enough cognitively that they can tolerate any brain drain that the DBS puts on them in exchange for the benefits they get. Does this person have Lewy body dementia? Or do they have dementia, period? Or just how are they doing? We want to get a baseline. They're complaining of some memory problems. We just kind of want to get a picture of where they are now. They seem to be doing pretty well overall. Let's track them over time. It just depends, the things about treatment decision-making, just practical decision-making. A lady earlier today asked a question, should you get tested when you first get your diagnosis? And she said, would it be good to get a baseline right off the bat, even if you don't have symptoms? And my take on that was, well, maybe. It depends on what your situation is. If you need to make decisions that you need to show you have legal capacity, like you're of sound mind, if you need to measure how fast you might be declining because you don't have a support system where you need to make timely decisions, you need to make plans about things, that might be something. If you're in a profession where you need to know that you're still safe, or you can get yourself in trouble either managing money, running machinery, or cutting on people, stuff like that. There's all sorts of reasons that you might want to do that. In general, my philosophy is you test people for cognitive issues when they begin to have them, or if there's some other agenda that needs to have it. So, if you just get one for fun, it's good for my pocketbook, but I don't think it's necessarily clinically indicated. I like to kind of wait until people say, I'm worried about this, or I have a symptom I need to get checked out. So if we could change it the other way, I guess we'd all make life would be great, but I don't think I'd like it. I don't think that's a good way to go. Functional information. The key thing that I am interested in out of this, the diagnostic questions, usually it's one or two check boxes for doctors. Are they demented or not? Can they drive? Whatever. Great. Well, that's 8 hours of a lot of time spent, and about 15 hours of my time spent writing it up and putting it all together, going yes or no. If we're going to spend all that time, I want to come up with some answers. I want to come up with some kind of product out of this. And so the things that, the questions that I'm always interested in is, what's different cognitively and how much? You think you may be losing your mind because you're slipping a little? This is real common. If you think you're off a little bit, you don't have a real good kind of a measuring stick to see it feels off. Am I way off? Am I a little off? Am I going crazy? Or you may be, I'm perfectly fine. They're saying I'm crazy. I'm not crazy. Who knows? But you get some objective measurement there of cognition, and I think that's it helps you kind of ground yourself. With testing, we can find out, look, you're doing great on a lot of things, and that's important to know. If you think you're losing your mind, look, you're really holding together well. You're not losing your memory. You have some deficits here and here. That's useful information. It will help you kind of go, oh, I can relax. I can kind of trust my own brain. Or family can go, oh, that's why they seem quiet and detached. They have hypophonia, need to go to PVP, and they need, we need to figure out what's going on with them cognitively and get them on the right meds. Different from Grandpa's in the corner. He's gone. He's left us. He's just sitting there day in and day out. They said he had Parkinson's. Oh, well. And that's what people do. You got to, Samantha was talking about pushing back earlier. How can you advocate for yourself? This is how you do it. You make sure you're getting good care. You make sure you're defining the problem. Make sure that you know what's going on and that the people who advocate for you know what's going on and can define it, not just on, off, out of it, okay. And unfortunately, that happens. We can figure out, is it across the board or is it certain areas that are getting affected by it? How severe is it? Are things really, you've got a shouldn't be driving type thing, or you need more help than you think you need, or you don't, you're doing all right. When to help versus stay out of hair, that's for family. To help them understand, I don't need to get in there with them. They're good with that. Versus, get away, woman, I got this figured out, leave me alone. Well, it may take longer, but they can get it done possibly. With things like driving, financial management, medication management, living independently, et cetera. Now, when you go in for testing, good coffee, yeah, because I drag your posteriors out to my office about 8 in the morning, because we got to get started. We want to try to get it done in one day. If we need to split it up into 2 days, we can interview one day and test another day and be reasonable. But most people want to make it one day. So when you come into the office, you've been told a couple of times, here's what's going to happen, or here's a place to go look on our website. In case you didn't look there, which nobody does, and in case you were up all night worrying, I start off by saying, let me tell you what we're going to be doing today. And here's what the deal is. And I'll tell them, we're going to be doing, I find out about them a little first, of course, and say we're going to interview them, do testing at first. Let me tell you what we're up to. Here's what the day is going to go like. And so we'll start with telling them, we're going to be doing testing. This is ways of looking at your thinking abilities. We're going to measure a whole bunch of different areas with a lot of tests that compare you to other people of your age, sometimes age, education, gender. So we will know how you're doing compared to where most people your age are in each of these different areas. And I give them the blood test analogy, explain to them this is all face-to-face. For the most part, it's interactive. No sticking, no poking. They can quit anytime they want. They can take breaks. They're a collaborator. I was just telling you, you're collaborating with us on a data collection process. We want you to, you're helping us, figure out what's going on. You're not just a passive, specimen on a slide. So, they start, okay, well, that's not so bad. All right. So then we get the history. And the history involves, how I want to know everything about from the first time looking back, the first time you started having symptoms, you now figured out were Parkinson's. And let's take it from there up until now in terms of the pattern of symptoms, when you got diagnosed, what they called it, how they treated it, how you've responded, how it's affected your life, work, home, whatever. I want to get the whole timeline up to now. Then I want to know about the current symptoms, the current functioning in terms of activities of daily living. Are they able to do stuff on their own? Are there things they can't do on their own? And when the wife starts saying, yeah, he won't bathe for like 3 or 4 days until I make him get up, I'm going, okay, now we're talking what's starting to sound like a frontotemporal degeneration, behavioral variant probably, maybe Lewy body. But you see those things with that. But so the information I'm getting is not just factual, write it down. This is all diagnostic stuff. We talk about current symptoms, a range of physical symptoms I want to know about, cognitive symptoms, things we hadn't talked about so far, any other physical or emotional or behavioral changes. Because when you just interview, you get information. But sometimes you have to go back, loop back, and make sure you hit all the notes to make sure you didn't miss anything. And a lot of times you'll find things that they weren't volunteered. Then I want to know about the person before all this in terms of their early life, developmental history, family life, family history, medical history, their work history, school history, work history, all of that. That's all important because we're looking at this person. We need to know kind of who they were before this happened so we can, make sense out of some of the data we have. So if a guy was a lawyer and he's got an 80, kind of a low-end verbal skills on testing, I'm going, that's not where a lawyer's supposed to be. And if somebody was a mechanic and they're also really low down there, it looks like their spatial skills aren't so hot. Something's going on with this person. But if they were a mechanic, or were never all that good in school, they were really good being a mechanic, and their verbal skills weren't all that great to begin with, like schooling wasn't selling what they were buying, you will see, you'll go, well, that's kind of the way they always were, I think. You can guess from the history that we don't interpret that as anything other than probably more like that than not before. So you can't just blindly interpret the test. You have to know who you're talking about, and you have to have their history. So that's where the interview comes in. Now the testing, the coffee is free throughout the day, so I like to keep it going anyway. But the testing is all pretty much face-to-face. What I'll tell them is the tester's going to be asking you questions. You'll be sitting across the desk just like with me. They'll be asking you questions. They'll be putting stuff in front of you saying do this or that. They'll be saying put this together, fill this, do this pencil and paper thing. All sorts of different types of tasks. There's a couple of things on the computer that aren't, it's not complicated. So can you hit the mouse when they flash a 1 or say 1 on the computer, and don't hit it when you hear it or see a 2. So you don't have to be, Steve Jobs to figure that one out. So there's things, and we kind of just start explaining, that this is what it's going to be like, and you can stop anytime you want. There's no sticking or poking. If anybody pulls anything out sharper than a pencil, run. They've obviously lost it. I have a tester that's been with us for 21 years, nearly 22, and I know she's going to crack one day. She's just got to. Imagine working with me for 22 years. So anyway, she hadn't cracked yet. So, but I tell them you can take breaks whenever you need them, ask questions, give observations. It's a real collaborative kind of process. And then by the time we get to that point, usually people are a lot calmer about testing. They're going, this ain't so bad. This could be a lot worse. And then they're going, all right, I wasn't sure about this when I got here, but now we're doing all right. So that works. Now, I've seen people that go to the neuropsychologist, and they'll get a 15, 20-minute interview. They put them through testing. Nobody talks to them really. They just do the tests and then send them home, and they don't have a feedback session with them. I'm going, that's the craziest thing I've ever heard in my life, because my philosophy and also just standard practice is when you accept a patient under your care and you're doing testing, they are your patient. Doesn't matter if they're somebody else's patient. You're responsible for the whole range of things you do with them. So ethically, if you are doing testing and they need to know and want to know, unless there's some, unusual circumstance, you need to give them ample opportunity to go over the test results with them. If you can't do it in person, do it by phone. The doctor can review it with them, but the doctors aren't really skilled enough in our field. Just like I'm not skilled enough to read MRI scans and make anything out of it. They're fun to look at. I see all kind of things, but, it's not my field. This takes a lot of years of training to be able to then take a bunch of mental monkey shines we do with somebody for 4 or 5 hours, score them up, put norms and scores onto them, and then say something meaningful back to the person. They go, man, this helps. This makes so much more sense. It tells me things I didn't know, and this helps me understand this better and have more to do with it. So it's really, really important to go back, sit down with a neuropsychologist, have them go over the test results with you. And, my format is to say, okay, I put all the guts in my report up front, all the important main points, because by the time you're 4 or 5 pages into it, you'll probably be asleep. So I figure I'll hit you with it while you're fresh. But what I'll talk about is, here's the pattern of test results. Here's what you're strong at. Here's what you're weak at, just in my report. Yes?
If you are taking the test and nobody's contacted you, should they contact you, the doctor contact you, or should you contact them?
Well, if they're not calling you, I'd call them back. But when you're in there, they should make that as part of the whole service, is going over the test results. The CPT code says neuropsychological evaluation with testing and report and feedback. Feedback's to you. You're the one that's the customer here. So they should be, we schedule it when they're in there. I schedule them personally when I'm done with the interview, say, let's get you set up for the return visit now. And if I fail to do that, I make sure my staff does that before they leave that day. And they come back and we spend, on the light side, an hour and a half, on the longer side, a couple hours, sometimes more if I can't shut up. So, but this is where the action is, with you're getting the benefit out of the testing. Otherwise, there's yes, no question answer for the doctor with 8 hours of both of our time. That's kind of dumb. Yes?
Yes. Are these tests used to determine mental competency if there's a hearing?
They can help with that. Let me tell you about mental competency. Just mental competency with the law, it's not based on a diagnosis. It's based on your capacity. It's mental capacity is the word that they use. Competency is if you're competent to stand trial. Capacity, you have testamentary capacity, meaning can you change your will? Testimonial capacity, if you testify, can what you say be considered reliable, or is it going to be unreliable because your brain isn't working right? Or contractual capacity, can you understand the implications of a contract if you were to sign it, where you have sound enough mind? Those are behaviors that I don't care if you got a cannonball shot through your head, if you can show that, the law says you got it. I was on a case with a woman who had PSP, who died shortly after her diagnosis, and the experts from the other side said, oh, well, she changed her will. She didn't have testamentary capacity, she had PSP. progressive supranuclear palsy. And I said, well, that's irrelevant because the law isn't written around, if you have this diagnosis, you're obviously incompetent.
So the competency is a relied, there's no actual score a person has to make to be above that? They're competent?
No, it's not that simple. If somebody is just profoundly impaired on testing, they can't put two and two together on anything, it's pretty fair bet that they can't meet the basic criteria for contracts, marriages, wills, but they have to show that. It has to be demonstrated that they do or don't. Which is
So a case has to be made, in other words.
This can provide support to that, but
Okay.
like that lady I was telling you about, she had testing done. She had some impairment before. I didn't test her. It was a legal case. But, she certainly wasn't grossly demented and certainly could make her will changes any way she wanted. Did it with a videotape. Did it with a doctor and a lawyer and her best friend. She meant business.
Thank you.
So capacity is different. And test scores don't make decisions based on that. They can be supportive evidence, but the behavior is what really matters there.
How likely is it for you to discover in the course of administering one of these tests or the feedback session that someone who did not know he or she had Parkinson's, how likely is it for you to be able to determine that with this test?
Not really from the test. I've had people come in for other reasons. They're having cognitive problems, and they had the bradykinesia type Parkinson's, and as I was talking to them, I'm going, this guy's got Parkinson's. This guy really got Parkinson's. And by the time, we were done, they had a Parkinson's cognitive pattern, but the real issue was not, they weren't there to get diagnosed with Parkinson's. I just said, you need to go see a neurologist. I think you have Parkinson's, and he did. But the diagnosis of Alzheimer's is real clear on testing. Diagnosis of, it's like, oh yeah, this is, very little is like this. I'm not going to diagnose Parkinson's on the basis of a cognitive profile. It's a clinical physical diagnosis with a lot more parts than I'm trained. So I'm looking at the cognitive and behavioral parts of it. I can suspect it.
Thank you.
But I'm not going to diagnose it formally. A lot of times it's used to determine if people are trying to take disability and oftentimes need to, or the testing can help say, look, they're carrying a load already and full-time work for this person, competitive work is probably too much. If you have something where you need to show capacity to work, I'm sure it might have some benefit there. It just depends.
Can we ask our doctor to recommend us for?
Yeah, you can just call the office unless you're on HMO, because we don't have to have a referral except under certain insurance plans, which only take two. But in Texas, we're freestanding entities. In other words, you don't have to have a physician referral, although it doesn't hurt. Some plans.
Question back here.
Yes.
I'm really glad I came today because my neurologist had arranged this testing for me. And after I had taken the testing, which was probably 6 hours, broke for lunch, I asked the person conducting the test, when will I get the results? And she said, well, we're going to give them to your doctor, not you. So when I went back, I found what was the results of my testing. And she said, well, you don't have dementia and you can now start driving. And that was it.
Well, unfortunately, I think sometimes in bigger institutional settings, you may see that it's too compartmentalized. This is your life, your brain, your time, and some critically useful information in there. Just takes, I think it's, you could always call the neuropsychology people back and say, I'd like to come in and review my results with you. If they don't want to, you can say, well, isn't it incumbent upon you to do that? By the way, I'd like you to release my report to me. You should have a copy of your report. You should have someone, but you can't get a copy of your report technically from the psychologist unless they go over it with you. That's a rule we have to go by.
Are these services covered in the Medicare?
Yes.
That's all.
Yeah, for Parkinson's and these services, yeah, that's a clear yes on that. Yes. Oh, sorry.
Me?
Yeah, I think so.
Doctor, you said that you don't necessarily recommend that someone get a baseline test simply because they've been diagnosed with Parkinson's. Would your answer be the same if that person had a family history of dementia?
If you, yeah, I mean, a lot of, if they have Parkinson's and a family history, or just regardless?
Both. They
You know,
have-
if you're concerned about progression, and you need to know, there's certainly every reason in the world to do that if it makes you more comfortable and has a purpose. I don't have any problem if somebody comes in and says, I just need a baseline, I have Alzheimer's in my family, I need to see how I look, you know, I need to know what the memory problems I'm experiencing are day-to-day memory problems, or is this the beginning of that? So, I mean, you know, a lot of times it's important just to allay anxiety. Like I said earlier, though, if you're in a position where your mental status is being scrutinized, like if you're a physician or a pilot or something where you're under, you know, high scrutiny, it'd be good to get a baseline, I think, because if you're having trouble, something goes wrong later, so look, I got this baseline back here, and I'm still here now, because you know if you have Parkinson's, or if you're old, or if you have some impairment, that I don't care if you get rear-ended, you're the one that caused it. You know, you're the one that's always going to be the suspicious one, and your disease process is why you made that mistake, regardless of whether it was or not. You know, I mean, that gets the blame, and so the hairy eyeball points your way.
And would that baseline require a referral from the neurologist?
Not if there's a diagnosis. I mean, it helps. I mean, with Medicare, it's always good if we have a, you know, referring doctor was, we can put it on the claim form, but you're free to walk in on self-referral. Is that
Thank
right,
you.
Office manager?
I have a client with Lewy body dementia.
Yes.
She was diagnosed about 4 years ago with a neuropsych eval. And her neurologist, she's actually been hopping neurologists because of her daughter, but she was referred to a psychologist. Her daughter has not yet taken her. So do you, as a professional, just do the neuropsych evals, or do you actually see clients for subsequent visits?
We see clients. I mean, we're available, and some people, if they're needing, you know, short or longer-term intervention, or if we're working with families, you know, yeah, I'm trained as a therapist first and a neuropsychologist second, and yeah, we do real follow-up with people. That's one of the other part of what we do is supportive. I call it supportive adjustment counseling, because when people have some kind of disorder, it's not that they're nuts. They're dealing with a crazy situation, and they need some help kind of using their resources to cope. And if they got, you know, a psychiatric problem, well, you know, that's different. That's we treat that as well. But we try to focus most of our therapeutic stuff on people that have neurological issues, because there's a lot of really good therapists around that may not have that expertise, and we do have that, so we try to limit that.
There was this is more of a comment than anything else, goes back about 7 years ago. There was a request by the neurologist to have a test for cognitive values only. She was driving, and he was concerned about that. And the whole answer to the whole thing was a recommendation to stop driving. But I don't recall, it was a very short test, probably an hour.
There's a Cognistat is probably what it was. It's a computerized test that the Psychological Corporation, who's the one that publishes probably about 50-60% of the tests that we make, and we're their primary audience, they decided to start selling that to physicians. And it's okay if physicians, I mean, one of my referral sources uses that a lot when somebody has cognitive problems, and if they got problems, they send them over to me to look at them more. If they don't on testing, but they still have concerns, they'll send them over. So it's not like they do or don't. But there are a lot more complicated issues in determining things like driving, et cetera, than just scores on a test. I mean, the scores will probably tell you something important, but do you want to make all decisions based on that alone? And if you ever have a psychologist that doesn't want to interview you, just say, no thanks, I'm out of here. I had a neurologist once tell me, I just want you to test them, just give me the numbers. I'm like, well, no, I'm sorry, I can't do that. That's unethical, illegal, and just plain improper. Yep.
I just wanted to thank you for including attention span in the testing, because I thought maybe had been ADHD my whole life and never knew it. And now I know it's just part of my Parkinson's.
It may have been, but the Parkinson's is if
Yeah.
not before the Parkinson's.
Thank you
is
for
certainly
including that. That's all I wanted
the
to say.
primary hits you take is attention. Certainly on the testing. If I'd had all my slides together, I could have shown you the, kind of the pattern that we get compared to other folks. Anybody else?
So if a family member was questioning the capabilities of somebody with Parkinson's or the competency, would it be beneficial for the patient to self-refer them for a neuropsychological testing, or is there some other type?
Well,
Would it help?
if they need to know what's the person, how are they functioning? Sure. If there's questions about functioning, sure. I think you get more information from that than just superficial impressions.
I think
including
unfortunately,
identification.
some people, if they read information on the internet or, they're comparing Parkinson's to Alzheimer's, they're thinking that this person with Parkinson's is incompetent when maybe in fact they aren't. So how would part of the patient advocating for themselves be to perhaps go through the neuropsychological testing so that that information could be included with any other information that's being gathered?
Yeah, I think so. If you're in a situation where you're kind of they're trying to make you black or white, you're broken or fixed, and you're competent or not, and you could say, well, let me take a smarter step. Why don't we go get this objectively evaluated? It's like if you say, you shouldn't drive. Why not? Just because you shouldn't. Well, the patient should, at that point, the person in question should say, well, why don't we go down to Baylor Rehab and do an adaptive driving evaluation, and let's get the facts on this and let somebody that knows how to make that determination get some data and maybe make a more informed decision about that. And this is kind of like that, although, again, it's more in terms of practical day-to-day stuff, more so than legal determination, although that helps some. It can help with that.
Okay, in my situation, there was a neuropsychology test on me. If I could get that report, is that something you could look at? Or would you want to conduct an entirely new one?
Well, I mean, I could certainly look at it and tell you if I could, clarify things or explain it better.
Okay. Well, it wasn't explained to me at all, so it'd be better what I know right now.
If I could get scores on it, it'd be really good. If there's scores, that helps.
Sure.
Some neuropsychologists write a report where they just do verbal descriptions, no scores. That's kind of the thing of the past. More and more now we put our scores in reports so that they're transparent to whoever needs to look at them. They say, here's why they're saying what they're saying, here's what the scores were, here's how they describe those scores, and here's the conclusions they're reaching based on these scores.
Okay, just one last question. What do you know about the Rytary drug for Parkinson's?
The what?
Rytary?
I don't.
Okay.
Right, was there a...
R-Y-T,
I know the medication. I don't
R-Y-T-E-R-Y,
know.
yes.
I don't know enough to give any insight.
Another question is, I've heard that car insurance companies will not give you car insurance if you put down that you have Parkinson's. Is that true? Have you
I
heard
don't-
any feedback
I haven't
on
heard
that
that.
at all?
It opened.
Because that would be discriminating against a physical, excuse me. I had the same thing going on. I had to get hand controls.
Yeah.
And I actually came out and asked my insurance company, are you going to raise my rates because I have hand controls? They said, no, it's illegal. It's discrimination. So that would be discrimination.
Yeah, for what it's worth, call the Texas Department of Insurance. To consumers, they're probably better than you are to providers of services, but they can answer. And you can actually go on the internet and probably look that up under the Texas Department of Insurance rules as to, but if they do not renew your license because of a diagnosis other than blindness, or you can't operate controls in some way or another, I mean, it's like competency. Oh, you have, You have PSP, therefore you obviously don't have testamentary capacity. She was asking, should one be tested when you first are diagnosed with Parkinson's to get a baseline? That's a good question. You know, my stance, I guess if you want to keep a running tab on how you're doing, and that's important to you to do that, you could do that. I don't think there's anything wrong with that. I tend to say, let's wait until someone is concerned about how you're doing. But if you need to know, okay, I'm starting to slip some in some areas, especially if there's specific reasons from a work or financial standpoint or decision-making standpoint or whatever the demands on you are, or planning standpoint. If you live alone and you're going, okay, so where do I stand now? And, you know, am I losing ground? I need to make plans quicker for more support, or am I pretty stable? I mean, questions like that, yeah, I think that would be reasonable. I got diagnosed with Parkinson's. Medicine's working great. I feel okay. Nobody's acting like there's anything wrong with me other than, you know, my physical symptoms. I wouldn't rush out to the neuropsychologist right off the bat. I tend to go on a more need-driven basis. And the same with coming back for testing. You know, somebody says, you need to come back every year, and we will test you once a year with a full battery of tests. I think that they are going to be very successful financially. You know, but I don't know if they can sleep they can probably sleep at night, but I wouldn't be able to. I think, you know, I tell people, when do I come back? Come back when there's something that changes. Come back when the information you got here doesn't answer the questions anymore. Come back when somebody else is worried about you in ways that they weren't. And, you know, usually we will do pretty much the full battery of tests again, mainly because if you pick and choose a little bit, you don't get the whole picture, and it can be distorting. I did that recently with a guy with a head injury, going to trial soon, and so I tested him just a few things a year later, thinking everything will stay stable. Now he got better on some things, and now I'm like, uh-oh, we got to get him in and do the whole works. So it's a little tricky to do spot checks, but we'll try to, you know, we try to minimize the overkill. Yes?
Erratic sleeping at night, or lack of sleep, or REM sleep, and then dozing off and on during the day. But how much is sleep affecting the cognitive?
A lot.
A lot.
I think it does a lot, particularly, I mean, on testing. What I see happening on testing is this. You know, you've got kind of a circadian rhythm that you go with, and people come in and they'll say, oh, I slept horrible last night. But you see them in the middle of the day, they're doing all right. I mean, at 5 this morning, when I was going, oh, my God, what am I going to do? I was wasted. But this morning, you know, I'm still a little, not quite right, but I'm sort of in the flow again. And so I think that you may see some subtle effect on testing with sleep, people being up the night before. But if they're falling asleep, yeah, we send them home. If they're like, you know, I can't stay awake, or I'm not. But I'm just thinking from a testing standpoint, you're asking more generally. Yes. Yeah, I mean, you know, Parkinson's, like any neurological condition, particularly movement disorders, is real vulnerable to, you know, imbalances or disturbances in maintenance functions or in your emotional state. You know, like when people come into the office, they're worried, they're kind of shaky, they've been on the road for an hour going through traffic, they were up too early, they took their meds, and now they're starting to run out early. You know, so things that destabilize your system, short-term or long-term, yeah, they're going to diminish your functioning. So sleep is critically important to iron out, not only for the motor symptoms, but for cognitive symptoms, for sure.
When I go to various doctors or testing, my husband's usually with me, so he catches things that I may not catch. And so we've done that for a while. But on something like this, how active a role should your spouse or caregiver or partner have?
As much as you're willing to let them. We want family to come in for the interview. I mean, they don't always. And if they don't because they're going, I don't need to, you got this under control, that's one thing. Mm-hmm. But generally, we like them to be there because they may see things you don't. They may remember things you can't remember when that was, or they may have observations about things, or about your character. She's always been this way, you know, and this, of course, applies to this. You can also get a gauge on how the spouse is reacting to all this. Sometimes the spouses are looking like, you know, how soon can I get out of here? And other times, they're very, very invested in doing everything they can to be available and be there. I want the spouses there on return visits every bit as much, if not more, when we go over the test results. And the reason, unless the person says, I don't like them, I don't trust them, I don't want them knowing my business, I feel vulnerable to them. So it's really the patient's choice who they bring in. But we, in normal circumstances, would always want spouse, kids, whoever is in your system, whoever needs to know about what's going on and wants to get
And just
bigger picture.
a follow-up, but a different topic. I read this, and I can't remember where, but I had read that at a certain point, you cannot learn new skills, that your brain is not going to let that happen. So,
Like what?
I don't know, like how to make coffee or how to do something. But that's probably not a good example, but more the issue is somebody wants to have me play golf with them. I've never played golf. I don't know how to do that. So, but what I was reading was that the skill you need to pick up new skills, it's not there.
With what disorder?
With Parkinson's.
Well, Samantha, I bet you better shut this place down. Let's get out of here. Break the rent, it's over.
So
I think that's
a big no
preposterous. I even went to a workshop a few years ago where they were talking about stepwise learning of teaching a procedure to people with Alzheimer's, which was, in one case, it was teaching this woman how to make coffee in her home. It was a Dutch guy, and it was a guy from Netherlands doing this. So he probably had lots of funding for him to go teach her how to make coffee. But the point is that there was a stepwise learning that even somebody that has minimal tread on the tire, minimal memory traction, no stickum, that they can learn a procedure. And with Parkinson's, of course you can learn new procedures. If it's something that involves high motor skills or something that involves multi-steps, multitasking, it's going to be more challenging. But why do they have dance classes for folks with Parkinson's? Why do they have all sorts of things? Why do 90-year-olds want to go learn a new language at community college? Because they say, it keeps your brain better. Of course you can learn as you get older. And Parkinson's not affecting memory. For the most part, in most people, it doesn't have a profound impact on memory. You can learn new things, and you should. And you should be pushing yourself to stay on top of your life as best you can. Yes.
How do you treat dementia, and do you treat the symptoms or the root cause, and as a result of the treatment, does the condition stabilize or reverse? Could you spend a few minutes on that?
Well, treating dementia, if you want to talk about Alzheimer's, what you do is you make sure the person's on medication that helps protect their nerves, their brain cells, and also keeps their memory system making connections more than it would without the medicine. What you do to treat it is you work primarily with the family to structure the person's world so that they are able to do more. They teach them how to flexibly move in and help, how to get them engaged in the world out there, don't let them withdraw. I mean, that's what you do with someone who can't really organize their own approach to managing dementia. Same with someone with Lewy body or other types of dementias. With Parkinson's, here's the conundrum. I think that cognitive rehabilitation approaches, or at least just coaching the person to manage certain things in a certain way at home in their day-to-day life, I'm certain that works. Medicare doesn't see fit to pay for that. But I think you can teach people, particularly Parkinson's, to be aware, because, they're doing it here. They think big, same thing. They're teaching you how to observe a deficit that you didn't really see become very deliberate in compensating for it, figuring out when you need to kick it into gear and do it. Now, that's what you do with cognitive problems, whether it's head injury, Parkinson's, or any other type of acquired or slowly progressive process. It's the same thing, same process you use in learning how to hit a tennis ball or a golf ball, in a sense. I mean, it's a process of learning. So use meds whenever they're going to be helpful. That's my belief, and you don't skimp on those. And treating dementia in the office, not much you can do. But if you're treating cognitive problems short of dementia that the person is aware of, they're concerned about, you can show them ways to work around it. You can work with family to help them stay on track with doing it a different way. It may be slower to learn new tricks, but they can learn them. People can learn them.
I believe we have time for one more question.
Okay.
I'd like to hit this, excuse me, Texas allergies. I'd like to hit this from a different angle. As caregivers, I think we're very cognizant of what our loved ones are going through, particularly mentally. Right. And I was wondering, as caregivers, what is your thought on supplements like EHT and some of these others that are supplements? I
think you need to ask a physician about that. I'm a psychologist.
Okay, but
so I don't have an opinion one way or the other.
You don't?
I don't have any better knowledge of that than anybody else.
One of the attributes of Parkinson's is apathy. How does apathy play against cognitive functioning?
Well, I think it works downward on it because the more you stay activated, the more you're going to stimulate brain functioning. Period. And you may need to have external prompts to get a person through the apathy. I saw a person recently, not with Parkinson's, but who had a very frontal lobe syndrome. She could think the first step, I want ice cream, but she couldn't think that, but it's not a good idea. Or I want to get out of bed and run around the house, but she wouldn't think it's not a good idea because I'll fall down and break my arm. And she sits, and her husband is going nuts because he cares about her, but he wants to take her out, go do things she won't. So, I mean, the prompt there is you have to agree to go out once a week to lunch. Let's start there, period. The apathy part, if you can't adjust that with meds, either to treat depression or to get the person more activated, I think the spouse and family are going to have to pull on this person to try to get them into a routine of tolerable activity. And that just means go out to breakfast, go out to lunch, do something tolerable, but get moving around, do things.
I know I fight against it, but I come here and I stay active, I do things.
Right.
I found the best battle of fighting is to be engaged in something.
I think one of the things that happens when you have lower systems in your brain right next to the emotional system, which is where the basal ganglia are, right next to that is the limbic system, which is the thing that kind of drives the get up and go part. People are waiting for the initiation part. Yeah, I need to get up and go, clean the bathroom. That's a great idea. Sure do. Need to do it. They sit all day like that. They're waiting for this emotional spark to hit, like a spark plug that's been gapped properly. And I think these things ungap the plug so that the charge goes out, but it doesn't reach. And you have to, if the person is aware of it, I think you can cognitively work with them on, you're going to have to tell yourself to do it. Just like you tell your legs, all right, legs, get up, move out of the car now. You have to actually be deliberate with that and not expect the automatic impulse to do it.
Well, I think that this description fits live life with intent.
Absolutely. I think when these guys here came up with that, it was the most elegant, meaning beautiful, simple, right to the point. Yeah, but it was just it covered not just speak with intent, not just move with intent, but live with intent. And I just went, man, that's the coolest thing ever. Absolutely.
I have a
question.
Yes.
You said that with motor skills, everybody with Parkinson's is different, but you see more of a similarity in cognitive skills.
I do.
Okay, how long after diagnosis of Parkinson's do you see the cognitive degenerate? How usually?
You know, we looked at that when we compiled the data from about, I think it was about 10 years of Parkinson patients. About 5 years. We washed out everybody that wasn't just straight Parkinson's without other issues. It was hard to know. Onset between time of diagnosis and beginning of cognitive problems was real variable. So there may be some algorithm out there that explains that. In our data, we didn't see it. And I think it is individual enough that that's not unusual. That's not surprising to me.
And
Dr. Fulbright, what do you see in the horizon for, are there any super drugs coming or anything hopeful?
Well, not my expertise area, as good as one of the neurologists. Keep on calling it Nucalma, but it's not what it is. The more specific version of Seroquel-like medication for people with Lewy body. I can't think of the name. I always blank on this. That was a good symptom management drug because it doesn't sedate people as much, and it cleans up the hallucinations in people with Lewy body generally pretty well.
When will it be coming out?
It is out. What's it called? Nuplazid.
Okay.
Now, that's not a disease modifier. That is just a symptom manager that helps people when they have hallucinations. It turns them down without sedating them as much as a traditional antipsychotic, which is just a dopamine downer. If you have too much dopamine from the meds, that can push it down. If you have Lewy body, that can kind of settle down the hallucinations. In terms of cures or new treatments, you need to talk to somebody who's way further out there than I am in terms of the medical side.
Dr. Fulbright, I want to find out how patients can be their own advocate. Over the 20 years of treating people with Parkinson's, unfortunately, we've come across some where the family puts Parkinson's, lumps it into the same category as Alzheimer's, and may think that perhaps because the person's cognitive skills are slower, that they are not competent. What can the person with Parkinson's do to advocate for themselves if they find themselves in a position where they don't have the support that they need? And what should they do?
Well, first of all, if they can get to a safe harbor like here, that's fantastic because there's other people around them that validate that. Testing, if they come to me and the family is going black and white on, if you have anything wrong with you, you must be demented, you must have Alzheimer's. And, that is, even with Alzheimer's, that's inappropriate to do. But with Parkinson's in particular, Parkinson-related problems in particular, it's just, what you can do is try to educate the family. I don't know what more to do other than that and fortify with the patient and get the person in the community and make sure they got friends that look out for them if the family doesn't get it. Main thing is educate the family, starting with the one who's the most likely to be sympathetic.
Would it be maybe going to a professional and then getting the professional to educate the family for them?
Yeah.
And then you also mentioned something very important that we don't hear very often. We hear a lot of people getting neuropsychological testing, but unfortunately, our patients are not necessarily receiving the second half, which you mentioned, the follow-up,
right,
where you go over the results and explain it and then take some action. So at the time somebody makes their appointment for neurological testing, should they go ahead and talk to the scheduler or whoever about what is the follow-up going to be after the testing?
Absolutely. I scheduled the appointments myself with the return. When I get done with the interview, I say, now let's set you up for the return time now, for one thing. The American Psychological Association's Code of Ethics is very clear. You don't test people and send them a report. If you do not sit down and explain the report to that person, you are creating a bad ethical violation by doing that. Just send them a report. Who's going to read? No telling what they're going to read into all this crazy psychologist talk in there, right? And secondly, the thing that's disturbing, or it's unfortunate, and not always horrible, but it's unfortunate. Physicians, when they get the report, they'll hand a copy to the patient. And I ask them not to do that because I'm going to go over this in a lot more detail. They might say, well, it says here you have some kind of dementia, so they're going, oh, great, got Alzheimer's, and out they go. And then for 3 weeks, we're waiting to get to them, and they're trying to unexplain that.
We have one time for one last question here in the front.
Driving is a behavioral test, again, not a diagnosis-based skill.
I'm concerned about if you should or should not put on, let's say, a job application that you have Parkinson's disease. Is there any kind of prejudice against that kind of thing? And is that legal or illegal? Do you know?
I think it's illegal for them to ask unless you have a disability for which you're going to be asking accommodations.
Okay.
I mean, that's the starting place from what I understand. You need to check with an employment person. However, if it's a job where you know you're going to need accommodations, you probably need to tell them, because what will happen is in the first few weeks of the job, you're not getting them, you're going to crash and burn, and it's going to be a mess anyway.
Yeah.
And they may go, well, thanks for telling me, we can work with you on that, or why didn't you tell me this is crazy, what's the matter with your judgment? So I think you can have either one of those outcomes. They can't ask you. They can only say, is there something you need accommodations for?
Okay, well, sounds like we have a lot of good takeaways from today's lecture. Let's thank Dr. Fulbright.
Thank you.
I think a few of the key points are that just because somebody is diagnosed with Parkinson's does not put them at higher risk for Alzheimer's. The cognitive issues in Parkinson's are very different from Alzheimer's, and also do not necessarily mean somebody has dementia. I thought the attention part, the difficulties with attention are very important, and I'm going to be using that for my Loud Crowd members. We're going to be talking about paying attention with intent, right?
That's it. That's exactly what it is.
That is basically a big part of it. It seems that would affect a lot of different things, your memory, your ability to drive, to do a lot of other things. So we need to use intent. And then I think one of the most important things we learned from Dr. Fulbright is that if we do go through that neurological testing, it is reasonable, neuropsychological testing, that we have a right to meet with the neuropsychologist afterwards to go through those tests and to have them explain to us. And
they have a duty to offer that to you and to take it real seriously.
And I can't tell you, I have, unless they're evaluated by this one here, I can't tell you how many people do not get that follow-up. So that was great information. Everybody, thank you for coming. We'll see you next month, second Saturday, and we will be talking about deep brain stimulation. So.